could start our day. Anyways, it's a pleasure to announce, welcome Dr. Eric, who is a colleague of pediatric space, a fellow Canadian, and a fellow Montreal, so there's a lot in common. Currently is assistant professor in the Department of Pediatrics, School of Public Health, Veterinary Medicine at the University of Toronto. He also practices there at the IBD Centre at the Children's Hospital of Eastern Ontario, Senior Scientific Director of the Information Technology Program at GEO Research Institute, and a scientist at right? Yes, okay. They changed. Eric chairs Canadian Gastroenterology Consortium, a national GI epidemiologist and pathologist, which epidemiology outcomes for health services research using the health element data from multiple provinces. By using Canadian GI epidemiology consortium is able to assess the picture of IBD in Canada, despite it having see all that really amazing data today. He also conducts research using routinely collecting data. Those of you who are interested in population using big database, I think really enjoys this lecture. Chairs of the Record Steering Committee, which is an international group, which has created reporting guidelines for observation studies that use data for epi and health services. He graduated from New York University, where he did his Bachelor's of Science in Biology, then went to medical school at the University of Ontario, or Western University, I think they call it. So it's my alma mater as well. And then did his residency at the Children's Hospital of Eastern Ontario, then did 5-year fellowship, including his PhD at the University of Toronto with ethics at 6, and then went on to do all that fancy stuff in 2010, and did the last 9 years. I think he's catching up to JF. It's over 100 publications. It's less than a decade of work, so he's really a super pediatric space, and so I'm really excited to
I took my notes. Should I do? Thank you. Thank you for the introduction. I'm really excited to speak to you today about this impact report that we produced that came out in November from Colitis Canada. I'm excited because I'm happy with the report. I'm really proud of what we did as a research network. And I'm hearing echo of myself back at myself, but anyway, I'll get used to it. Can we? No, it's all right. But essentially, I think this was an important report and an important demonstration of a research group that's. I'm still hearing myself back. It's okay. I'll get used to it. Get used to it. So, it was a demonstration of a research network that was able to produce a report really to advocate for patients and advocate for changes in health policy. It's actually not. To advocate for changes in health policy rather than just doing, publishing papers and doing science. And I think that was an important demonstration of us as a research network being able to do something different than just do science. We also consider this a living document, and we're planning on making changes online on an ongoing basis. So I'm interested to hear what people outside of Canada think of the report and what should be added in future versions and stuff like that. So I hope, please feel free to ask questions, and I hope there'll be time at the end to ask questions as well. No conflict. So the objectives of the talk are really to review the findings of the 2018 Impact of IBD in Canada report, which really helped identify gaps in knowledge and future research directions in epidemiology and health systems research, and hopefully be able to apply some of the findings to the American context. First, a bit of an introduction of who we are. Crohn's and Colitis Canada, similar to your own foundation, is Canada's largest funder of IBD research. It's been around for about 40 years, and in that time has funded about $122 million in research, which is really number 2 after your own Crohn's and Colitis Foundation in terms of international funding for IBD research, non-governmental funding for IBD research. Last year, they invested about $6.7 million in research funds to find cure and better treatments. And some of the key initiatives that many of you may have heard about were the GEM project, the Genes Environment Microbe project, run from the other Mount Sinai in Toronto, and the PACE project, which is a National Quality Improvement Network run by Jeff Wynn in Toronto as well, but involving 3 different provinces, creating quality improvement projects in adult IBD so far. And then my own research group, the Canadian Gastro-intestinal Epidemiology Consortium. So the way Canada's system works is that each province administers its own health system. So we really have 13 different health systems, 10 provinces and 3 territories. And so data is collected, population is collected in each province separately, and privacy laws prevent us from sharing data across provinces. So for many years, Manitoba has produced excellent research with their data, but they're a province of about 1 million people, so not very big. We recently have been able to use these data in Ontario, a province of 14 million people, but still it doesn't provide a national picture of what's happening with IBD in Canada. So what we did is we created this Canadian Gastrointestinal Epidemiology Consortium, or CAN-GEEC for short, because we're all data geeks. It's a national group of epidemiology and health services researchers who are experts in using provincial health administrative data. And what we do is what's called a distributed network analysis, where we create analytic code in one province and then modify it to the other province's data structure or variable names, but maintain the same analysis techniques, apply it to their provinces, and then if appropriate, we meta-analyze the results to produce a national picture of what's happening in Canada with IBD right now, but it can be applied for any gastrointestinal research as well. The goals of CAN-GEEC are shown there. It's really to create evidence. We're scientists fundamentally, so create evidence that will influence practice and policy. We do population health research, so we're looking to identify environmental risk factors, which eventually, hopefully, will be able to prevent IBD. We also want to try to improve the quality of care by conducting health services research and identifying disparities, gaps in care. We want to influence health funding, obviously, to try to bring attention to gaps and change how health funding policy is conducted in Canada. Obviously, raise awareness of IBD in the general population, and then serve as an example and improve the methodologies used to conduct research using routinely collected health data or health administrative data internationally as well. But in general, because we're health services researchers, we really do have a mind towards raising awareness amongst policymakers and hopefully changing health policy and the actual care being provided to patients with IBD. So a little bit of background on Canada. Obviously, hopefully many of you know where it is, just north of you. But the mantra that we've had for many years is that Canada has amongst the highest rates of IBD anywhere in the world. This is a systematic review of population-based studies published by Gil Kaplan's group in 2012. And you can see that not many countries reported prevalence of IBD at that time. But as you go later and later in the years, IBD is really identified as a disease of the Western world, where the rates are highest in North America and Western Europe, but particularly in northern countries in Europe, Scandinavian countries, and in Canada. Although the United States has a very similar incidence, Canada was really slightly higher for a long time than the United States. This was an update published in 2017, again by Gil and Suing from Hong Kong, updating the systematic review and comparing Western nations to Eastern nations, or developed nations to developing nations. And again, the message here is, yes, North America has the highest group of incidences, along with Northern. However, what we're now seeing is that IBD is increasingly global, and some countries in North Africa and the Middle East having almost as high rates of IBD as North America and Northern Europe. So it's an increasingly global problem, and therefore we have to turn our attention to, when it comes to health systems research, how we're going to provide care to these patients who are in places where care may not be optimal. So that's really one of the conclusions of the report in our epidemiology chapter, was that at the turn of the 21st century, it's no longer just a Western disease. It's increasingly reported in Asia, Africa, and South America. And while the incidence of IBD is still highest in Canada, and probably highest with the exception of some of the Scandinavian countries, the rates are rising more rapidly in places of Asia, Africa, and South America. So the incidence, the number of new diagnoses, are rising more rapidly in developing nations than places that have already developed. So in 2008, the first At the time, it was called the Burden of IBD in Canada report, or the first impact report was published by Crohn's and Colitis Canada. This was a 101-page report that was prepared by a consultant. It was prepared by Axia Research, based on the existing literature and pharmaceutical data to evaluate the economic impact of IBD in Canada. The estimates were really based on very few studies. There was some StatsCan, Canada research, the Canadian Community Health Survey, and the National Population Health Survey, which sampled, population-based groups of patients across the country. And so most of the research was based on who self-reported as having IBD. So they may or may not have actually had IBD, but that's what was available at the time. There was also Charles Bernstein's 2005 paper looking at the prevalence of IBD in Canada in 5 provinces. So what this report found was that there were about 201,000 Canadians living with IBD. Population now is 36 million. At the time, it was probably 32, 31. It was about 0.47% of the Canadian population. And that the total cost of caring for patients with IBD was about 1.8 billion Canadian dollars in 2008. The costs were dominated by hospitalizations, which you'll see has significantly changed since then. And there were about 1 billion in indirect costs, meaning costs, out-of-pocket expenses, lost work, early retirement, and early death. And so the total there ended up being about $1.8 billion. This was really also one of the striking findings in the report, based on pharmaceutical data that's publicly available if you pay. But essentially that even back then, when market penetrance of the biologics were not high, remember this is 2008, you had a huge amount being spent on the biologics compared to the non-biologic treatments. So this is the first stage in really identifying that things are changing very rapidly in Canada and here as well, in terms of what we're funding for direct healthcare costs in IBD. So in 2012, the report was updated and renamed the Impact of IBD Report in Canada. It was a 96-page report, again created by the consultants, by Axia Research, on behalf of Crohn's and Colitis Canada. This time there was a group of IBD epidemiologists and clinicians who were involved in creating the report and adding their insights. In this report, the number of Canadians increased to about 0.7% of the population, up from about 0.47%. And for the first time, we were able to identify the number of children living with IBD based on our research in Ontario. About 5,900 children were living with IBD at the time. The total costs in this report have gone up to about 2.8 billion compared to 1.8 billion in 2008. And the direct costs are shown here. So an increase from 700 million to about 1.2 billion direct healthcare costs. And you can again see that things have changed, right? Hospitalization and physician outpatient costs are around the same. That's outpatient and inpatient billing claims costs. But the medication costs quadrupled. A very sharp rise in the cost of treating with medication patients with IBD. And indirect cost was estimated to be about 1.6 billion. It's a little unclear of how that was derived, mostly by studies that were not Canadian. And so the accuracy of that number was in question. And even in the updated report, as I'll show you, it's still in question, and we need better research in indirect healthcare costs for IBD. So we as physicians and epidemiologists and researchers made recommendations in this 2012 report. And firstly, it was more funding for research, obviously, but not just cure-related research, which really was the mandate of Crohn's and Colitis Canada up to that point, was to find a cure, as I'll show you in a second. But we really did recommend epidemiology research to try to find the environmental causes, as well as research addressing the physical, psychological, and social issues of living with IBD. And I think that recommendation really made a change in the policy and the direction of Crohn's and Colitis Canada, as I'll show you. We recommended more investment in translational research and commercialization, educational programs for patients, open bathroom access policies, which we do not have a law. We still don't have a law in Canada permitting open access to bathrooms. Harmonizing the public and private drug plans. So in Canada, every province treats drugs differently. In Ontario, most drugs are funded by private insurance companies. And if you don't have private insurance, you get public insurance. And the way in which the indications for the drugs are very different if you have public versus private insurance. And Jeff Wynn has shown that you're less likely to get a biologic if you're on public insurance. And if you get a biologic, you wait longer for approval than if you're on private insurance. So the there's almost 2 different systems in Ontario, let alone other provinces, in terms of access to biologic medications. And then obviously improving drug review process, which is something that you all deal with here, and improving security and employer programs as well in terms of the indirect costs of having IBD. So we were fortunate enough to get a lot of attention outside the scientific literature in terms of this report. We presented it to policymakers. This is a picture of us presenting it to the Economic Club of Canada, to the business community and the pharmaceutical industry. And I think that really resulted in a change in Crohn's and Colitis Canada's direction. So before 2012, the mission of Crohn's and Colitis Canada was to find a cure, and that meant that's the type of research that they funded. They really were focused on the basic translational research, less so on clinical research, even clinical trials, and certainly less so on epidemiology, public health research, and psychosocial research for IBD. But I think when they realized the uptake of this report, both in the policy community, but also amongst patients, and how much attention it received from patients and donors, they changed, sorry about the white box there, but anyway, they changed the direction of Crohn's and Colitis Canada to finding a cure, but also trying to improve the lives of children and adults affected with these chronic diseases. And that has been reflected in the type of research that Crohn's and Colitis Canada is now funding, and the type of direction they're going to in terms of policy, advocacy, and other things. So this brings us to the 2018 report. So we were hoping to update it at 5 years, so 2017, but we felt that it was worthwhile to have a more rigorous process to update the report and review the literature for Canada. And so it took a while longer than we expected it to take, or than they were hoping it would take. We warned them that it would take that long. But anyway, I think they were happy with the results. So on behalf of all the co-authors, it's an honor to present this 2018 report. Our research group, CanGeek, partnered with Crohn's and Colitis Canada to produce this report. So it was different than the previous reports, where Crohn's and Colitis Canada hired a consultant and the physicians were brought in to advise. This was a report really from the scientists and the physicians to Crohn's and Colitis Canada. And so that meant it was formatted very differently, as I'll show you, and it was not written in lay language. It was really written in scientific language, and then Crohn's and Colitis Canada take the findings, translate it into lay language and advocacy documents, policy briefings, and bring those documents to policymakers. It's not intended for policymakers to read. So the objectives of the 2018 report were to update really all the relevant information from Canada based on new research that we've been able to produce over the last 5 years, raise awareness of IBD amongst the general public, patients, and policymakers, and then provide guidance, again, recommendations on changes that should be made to health, research funding, but also health policy and where we should be going in terms of delivery of care as well. So this was the structure of how we created this report. So there was a steering committee formed with myself and Gail Kaplan from University of Calgary. And the committee identified 25 clinicians and scientists with expertise in gastroenterology and health systems research. And then over the preceding 18 months, these individuals worked on 8 separate sections: epidemiology, direct and indirect healthcare costs, a chapter on quality of life in patients with IBD, complications of IBD, and the IBD landscape. And then we also had 2 special chapters, one on children with IBD, pediatric IBD, which is obviously my area of expertise and interest, and one on seniors with IBD, and I'll show you why that's important in a second. Each section was created using a standardized approach, including comprehensive literature review, teleconference and webinars to help with direction and planning, drafting of the sections, and an iterative review whereby members within and outside of each of the working committee reviewed each section, as well as expertise from the Scientific and Medical Advisory Committee of Crohn's and Colitis Canada. And then we had advice from Dr. Kate Lee, who was the VP of Research in Crohn's and Colitis Canada, as well as a consultant to help translate and format things properly, Jane Cook-Lauer. So the report was officially launched on November 1st with a media event in Toronto and online as a PDF. And then the Journal of the Canadian Association of Gastroenterology published all 8 papers, each of the chapters, as an online supplement. First, they published it online, obviously in e-publication format, and then more recently, it was published in a February issue as an online supplement and in press, in a scientific format. So you can get that all online if you're interested in reading So this was the structure of the steering committee. So myself, Gil Kaplan, names you'll recognize, obviously Charles Bernstein, Sanjay Murthy, University of Ottawa, Jeff Flynn in Toronto, and Alain Biton at McGill, with representation from Crohn's and Colitis Canada, as well as research staff who provided some services. And these, not that you have to read all of these names, but these are the different chapters within the report, and you'll recognize that some of these chapters are written by experts in the field in terms of conducting research. So let's talk a little bit about the findings of the report and start with the epidemiology chapter, focusing really on the rising rates of children and seniors. So the first thing that we noted was that the prevalence of IBD in Canada is now 0.7%. So that's risen from the 2008 report of 0.47% to 0.7% per day. That breaks down to about 270,000 people living with IBD in Canada. That's about 135,000 people living with Crohn's and 120,000 people living with ulcerative colitis, with an additional 15,000 people whose IBD we could not classify based on the databases that we have. They're not necessarily IBDU specifically, but they're not classifiable based on the codes within the databases. So the prevalence ranged from about 630 per 100,000 in Saskatchewan, all the way up to 1,200 per 100,000 in Nova Scotia. Most of the provinces were between 650 to 750. The real outlier was Nova Scotia with a prevalence of 1,200 per 100,000. And that's been described repeatedly, both in adults and pediatrics, and we really don't understand why Nova Scotia has such a high prevalence. And that's something that we really have to look further into. One of the main findings of the report is that the fastest growing prevalent group in Canada, the fastest growing group of individuals living with IBD, were seniors over the age of 65. And we're at the point of about 1 in every 160 individuals over 65 in Canada are living with IBD. And that has extremely important implications in how we provide care, or how you provide care, not me, I'm a pediatric gastroenterologist, about how you provide care in terms of caring for a more elderly population. And so why is this happening? For a number of reasons. So yes, we are diagnosing elderly patients with IBD, seniors with IBD, up to the age of 80 or 90 years old. However, the incidence is not rising so much in seniors. What's happening is all of those people who were diagnosed in their 20s and 30s in the 1990s, as the incidence was rising rapidly, are going to end up being in their 60s and 70s by the year 2030. And so this large group in the 90s who were diagnosed are going to need different types of care when they're over 65. And this group faces complications associated with longer course of having IBD, as well as additional age-related comorbidities like cardiovascular disease and diabetes, making IBD more challenging and costly to manage as our patients age. So our healthcare system and yours, I think, have to be prepared for this rising number of patients with IBD and all the complications that go along with it. And we need to be prepared to work more in multidisciplinary teams with other healthcare providers in order to be able to cope with these comorbidities and other medications and polypharmacy and other issues. So the seniors chapter really identified a number of gaps. Firstly, trying to find accurate ways of identifying seniors with IBD within our health administrative data, because unfortunately the codes are not as accurate in seniors, probably because they have other diseases that mimic having colitis and may be coded as having ulcerative colitis. So things like ischemic colitis, microscopic colitis. And so the codes don't work as well as in seniors. So we need to improve our way of identifying people within the data so that we can properly do population health surveillance. Obviously, changing the care and dealing with older patients with IBD and their multiple comorbidities is important. Understanding why these patients use anti-TNF therapy less often. Is it the risk of side effects that people are concerned about? Is it that the disease is more mild and doesn't require anti-TNFs? That's still uncertain. And obviously that brings to the point the role of other biologics in treating IBD, like vedolizumab. This report really didn't contain any information at a population-based level on these other biologics in elderly patients. This issue of polypharmacy, as I mentioned, how our drugs interact with the other drugs, and the cost of caring for IBD, for elderly patients with IBD, really is unknown. There's nothing from Canada on the direct IBD attributable costs or the indirect costs on seniors living with IBD. So moving on to my field, what I'm passionate about is children with IBD. And what this report found was that there were about 7,200 children living with IBD in Canada, and this represented about a 53% increase in the prevalence of children living with IBD under the age of 18 over the past 10 years. We're diagnosing about 600 to 650 new children with IBD under the age of 16 every year. These are data from our Ontario cohort, derived from health administrative data as well, looking at when people are diagnosed. The line graph there shows you that still the peak onset of, or the peak time of diagnosis, I shouldn't say clinical onset, but the peak time that they're diagnosed is still in the range of 20 to 30 years old. However, the teens are approaching those aged 30 to 40 in terms of the number of new diagnoses. The bar graphs show the change in incidence of over time. So the change in the number of new diagnoses that we're seeing, and you can see that the most rapidly rising group of new diagnoses are children under 10. Despite them being quite young, it's the fastest growing group. And that's followed by children aged 19. There was a statistically significant increase in incidence in adults aged 30 to 60, but not in seniors. However, the other important thing to note here is that no group is decreasing incidence. So it's not just that we're diagnosing patients earlier, otherwise you're seeing a shift towards the young group with a decrease in the older group. We're seeing more patients, there's no doubt. Whether that 0 to 10 group is earlier diagnosis, I think it probably is. For a number of reasons, they seem to be more clinically responsive to anti-inflammatory medications. They need hospitalization less often, and they need surgery less often. But I think we truly are seeing more cases in this young group, this very early onset IBD. And so I think that's something we need to address in terms of the reason why. And when you look at the relative incidence ratio, you can see that the relative incidence ratio, the ratio of numbers of children versus adults is rising. The ratio of number of children versus elderly people is rising as well. And the number of new diagnoses in the elderly versus adults is slightly decreasing. That all does indicate a shift to earlier age, either of onset or diagnosis. And I suspect it's probably diagnosis, mostly in the elderly group, decreasing in terms of incidence. So these are data from our Canadian Gastroenterology Epidemiology Consortium, where we looked at the incidence of pediatric IBD under the age of 16 in 5 provinces to see whether the findings that we saw in Ontario were similar to the other provinces as well. And the things to notice in this graph is that, firstly, 4 of the 5 provinces are all around the same incidence. And Nova Scotia really is that outlier, right? That green line at the top, they seem to have a higher incidence of pediatric onset IBD as well. Not sure why. When we meta-analyzed the results and pooled all the 5 provinces, it shows that Canada is, their incidence is about 10 or 11 per 100,000 people, children under 16. And really that's the second highest in the world, second only to Norway for children under 16. So it confirms that, again, Canada has one of the highest rates in the world. Because we pooled data from 5 provinces, we were able to look at age groups that have never previously been described. So very small age groups, 5-year age groups, like children under 5 years old, where the diagnosis is extremely rare, and we described the trends in incidence over time. And the first thing to notice is that amongst the 5 provinces, for the whole group under 16 years old, the incidence is rising significantly in Ontario and Quebec, which are Canada's 2 most populous provinces. In Ontario by about 6% per year, and Quebec by about 3% per year. However, when we meta-analyzed all 5 provinces, the incidence was only rising by about 2.1% per year, and you can see the left part of that diamond crosses 0, which means it was not significantly rising. So in Canada as a whole, children under 16, the incidence, at least over this time period, which was 1999 to 2010, was not significantly rising. However, again, we're able to break it down by very, very small age groups and rare incidence groups. And so we were able to look at children under 5 years old at diagnosis. And this was the only age group where the incidence was rising significantly. It was rising by about 7.2% per year, and that was significant. This change in rate meant a change from 0.55 per 100,000 in 1999 in Ontario to 2.23 per 100,000 in 2010, in Ontario, with very similar numbers in other provinces. And so, yes, it's still very, very rare to diagnose children under the age of 5 or 6. However, it's almost quadruple the rate of what we were seeing in 99. So a very significant rise. When we looked at the other age groups, 5 to 10, 10 to 15, and so on, the rates were not statistically significantly rising. Each of those groups were rising by about 2% per year, but it was not statistically significant. So this was the only group where there was a significant rise in the incidence. Yeah, that makes me sad. So based on having multi-province data, we're then able to do more predictive analytics to see what's going to happen in Canada in the future. And this study was published last month online in Gastro by Gil Kaplan's PhD student there, Stephanie Coward. And what she did was she took the data from 8 provinces, the prevalence data that we had from 8 provinces, and the trend from 2000 to 2008, and conducted 3 different predictive models based on economic predictive modeling to look at what the prevalence would be up to 2030 in Canada. And you can see there on the left is the historical data that we have from 8 provinces, and on the right, predictive modeling. So what she found was that the prevalence was increasing by about 3% per year, and that in 2018, 270,000, we estimated about 270,000 Canadians had the disease. And by 2030, that's going to rise to about 1% of the Canadian population, which is 400,000 Canadians. And so why is this rise happening? So in addition to the new diagnosis that we're making every year, and as you saw, the incidence isn't really decreasing, it's stable or rising in the young groups, people don't typically die of IBD. And so the number of people coming into the cohort exceeds the number of people coming out of the cohort, right? So you get the cumulative prevalence phenomenon where the prevalence will not decrease. And they did a calculation, the only way the prevalence will decrease in Canada is if the incidence decreases by about 75% to what it is, 7 to 25% of what it is today. So the likelihood of that happening anytime soon is very, very low. And we expect that this prevalence to continue to rise. So we have to ask ourselves, how is our healthcare system going to address these patients and treat these patients? And particularly in a public healthcare system like Canada, how are we going to be able to afford these patients? As I'll show you the direct costs involving for caring these patients, for these patients later on. Switching gears to pediatrics, again, my area interest, based on the same study, based on the same economic prediction models, and those gray areas show you the 95% confidence intervals, very narrow for adults, but in pediatrics, it's a little bit more wide because the numbers are smaller. But we're expecting the prevalence to rise from about 68 per 100,000 in 2008 up to about 160 per 100,000 in 2030. And we as physicians tend to think in raw numbers of patients. So the raw numbers in Canada are shown here, about 7,200 currently living with IBD in Canada. That'll rise to about 12,500 in 2030. If you compare it to American numbers, our prevalence really is not all that different. Those are the prevalence estimates by Mike Kappelman, who published in 2008, based on 2003, 2004 HMO data. And it's in people under 20, so it's a little bit of an older age group, but similar prevalence in the United States as well. And assuming that the rates go up the same way in pediatric IBD in the US as they do in Canada, it's going to be about 140,000 children living with IBD in the United States by 2030. So we really do need to think about how we're providing care for these patients, potentially changing our models of care, including multidisciplinary approaches in order to better provide services to these patients, because I think we're going to be losing the battle if we continue to try to provide care that we're doing the way we're doing it now. So gaps in knowledge in terms of the epidemiology was, as I mentioned, exploring why these demographics are changing, why is the incidence rising in children, what are environmental risk factors, evaluate how we're going to be able to provide care for these patients, and looking at multidisciplinary models of care in order to care for this aging population of patients with IBD. So I want to talk a little bit more about IBD in children and a special chapter that we had on IBD in children. It really does affect not just the child, but the whole family. And so this chapter of pediatrics, we really tried to focus both on the child impact and the family impact. We looked at environmental risk factors that cause it. We reviewed the genetic causes, especially a very early onset IBD, but also tried to focus on quality of life and how having IBD could impact on the academic performance of children with IBD, as well as the eventual employment opportunities and choices that the children make, but also the employment opportunities that their families face, missing work for doctor's appointments and so on, as well as the cost of caring for children with IBD. And Mike Kappelman in this 2008 study showed that in the United States, caring for children with IBD, the direct IBD attributable costs were double that of caring for adults with IBD. That's not a surprise when we think about my patient practice. About 50% of our IBD patients are on biologics. Up to 60 to 70% of Crohn's patients are on biologics, which is quite a bit higher than the adult IBD providers in the city. So we really need to figure out, what are we going to do with these costs, because the rising incidence in pediatrics, coupled with a very high cost of care, may make care unsustainable going forward. Again, makes me sad. The academic performance, so this was a study from Manitoba looking at the academic performance, linking their IBD cohort to Ministry of Education data, and they found that essentially children with IBD had the same academic performance and grade 12 enrollment rates, meaning lower dropout rates, as non-IBD populations. So they did just as well as the non-IBD population. The only predictors of poor academic performance in the IBD population were having a diagnosis of a mental illness and lower socioeconomic status. So not a surprise. But I think this was really important information to provide to families, that even though they are missing school and they're going for procedures, they tend to do as well as the general population, at least in high school. In terms of pediatrics, obviously a big focus is the transition from pediatric to adult care. And what we found in terms of the transition in the study from Ontario is while children did not have higher rates of needing surgery or being hospitalized after the transition, they had higher rates of emergency department visits after being transferred to an adult gastroenterologist, despite a spike in their outpatient visits to an adult gastroenterologist after transfer. So they were being seen by the adult gastroenterologist. They were not typically lost to follow-up, but they still showed up in the emergency room more, and they were not likely to be hospitalized after they showed up into the emergency room. So probably it's not a matter of flare-ups or disease severity. It's a matter of them not feeling comfortable accessing outpatient care. So the likelihood there is that pediatric IBD in Ontario, they have access to an IBD nurse by phone in all of the 6 academic centers, and most children are treated in academic centers in Ontario. And when they were switched over to the adult side, you were lucky to get an admin assistant respond to your call within the week if you were symptomatic or flaring. So they felt they had to, come to the emergency room to access care. And so, we could change the healthcare system in a way that gives them better access to their care. Obviously, psychosocial impact, transition readiness, and the like is the focus of pediatric IBD, and say Mount Sinai has really led this work in research by Laurie Kiefer, as well as Marla's work on the transition and transition readiness and psychosocial impact of IBD. I want to just bring to your attention this study that came out of our center, actually just published last week online by one of our psychologists, Janice Cohen, which prospectively validated the Intramed, a quantitative tool to predict psychosocial risk in newly diagnosed patients with IBD. We're now using this tool in clinical practice at CHIO to identify who needs more social work or psychology intervention early before they get into trouble with psychosocial risk factors. So this emphasis on the psychosocial model in pediatric IBD is growing. Hopefully we'll have more data to present at the next impact report update. So in terms of gaps in knowledge for pediatric IBD, why is the rate rising in the youngest children? How do we optimize healthcare in children with IBD? The lack of clinical trials is something we emphasized in the IBD impact report. There's really no clinical trials in children under 6 years old, despite this being the fastest growing group. And we really need to do better for these children to make sure that the drugs work the same way, same doses, same pharmacokinetics as older people. And then, as I mentioned, the psychosocial and family impact. So shifting gears now, let's talk a little bit more about the costing issues in IBD. So we did 2 separate analyses, 2 separate chapters, direct and indirect healthcare costs. So direct healthcare costs are healthcare expenditures for medically necessary services and treatments paid for by public and private providers, insurance companies, public payers, and others. And the Canadian data was really based on 4 publications from 3 provinces, Alberta, Manitoba, and Quebec. So really sparse data in Canada. But I'll show you there was also a chapter in this report, table 4.1, not a chapter, a table, which reviewed all of the international research on direct healthcare costs. So you're able to compare different countries and what the cost of caring for patients are. We also looked at indirect costs, and these are the estimates, the costs borne by individuals and society that are not covered by third-party payers. I'll show you examples of that in a second. There was very, very limited Canadian data on that, and so we extrapolated from other countries. These estimates were based on the median salary in 2016 and the IBD workforce of about 110,000 people with IBD who are in the workforce, should be in the workforce, age 18 to 59, and all estimates were inflation adjusted to 2018 numbers. And again, it was based on an estimated prevalence of 270,000 people living with IBD in 2018. So looking at the direct healthcare costs, the direct cost was about $1.28 billion per year, or $4,700 per patient. That compares to about $1.2 billion in 2012 and $700 million in 2008. We found decreasing costs resulting from hospitalization and surgeries, and that care by gastroenterologists actually resulted in lower hospitalization and surgery rates. That was a study from Manitoba. In addition, we showed disparities in care, where in Canada, rural patients were less likely to be seen by a gastroenterologist, and poor patients, despite our public healthcare system, were less likely to go on biologics and more likely to need surgery as opposed to the richer patients in the province. So there are disparities despite our healthcare system. This is the best study really that looked at the cost of caring for people with IBD in Manitoba, both in terms of all patients, about $3,800, $3,900 per year, newly diagnosed, about $6,600 per year, and long-standing disease, it goes down to about $3,600 per year. Slightly higher in Crohn's compared to ulcerative colitis. Compare these numbers to some of the American numbers that have been published, and we're about half of the cost of caring for patients with IBD. But the American numbers are showing similar to what we're seeing in that there's been a shift. So this is just in Crohn's disease. Brian Fagan's study from 94-95 compared to Mike Kappelman's study. You can see that over time, the hospitalization costs have decreased significantly, while the medication costs have increased significantly, obviously due to biologics being used. And then we updated some more recent data in that table that I mentioned, table 4.1, and certainly the numbers are not decreasing. So when you look at the other American studies, we're now in the range of about $18,000 to $22,000 per patient per year. So double what we were in 2003, 2004. Speaking about these patients who are starting biologics, the study was published in abstract form, but has been submitted, I think it's almost accepted to IBD Journal. But Laura Tergovnik took the Manitoba costs, looking at patients who start anti-TNF therapy before they start compared to after they start. The pre-rate, remembering that the average cost is about $6,000 in Manitoba. In the most severe patients who are going to start biologics, it goes up to about $10,000 before they start biologics. And then after they start biologics, up to $45,000 per year per patient. And that number, if you see these second sets of graphs, that really goes up if you're a continuous user. Not surprisingly, if you're doing well on the biologics, you're usually typically escalating therapy or changing the therapy, and those numbers actually go up. They don't go down over time, both for Crohn's disease and ulcerative colitis. So she found actually that reduced the biologic costs by 50%. So similar to biosimilars, right? So the biosimilar costs about 50%, at least in Canada, compared to the originator biologic. Only, this would result in less than 1/10 of anti-TNF users having a reduction in their direct healthcare costs in the year following TNF administration. So you would have to reduce the cost of anti-TNFs by 92% for them to be cost effective before versus after starting an anti-TNF. So that's clearly not going to happen. And so, the conclusion was that we really need to look in terms of studying these costs differently. We can't look at cost effectiveness just in terms of direct costs. We have to look at whether starting the anti-TNF is cost effective in indirect costs as well. Does it get people back to work? Does it get them contributing to the economy, and not just how much we're saving in terms of money? I'm going to skip this just in the interest of time, but this is what we found in terms of indirect costs. And again, a caveat that our estimates of indirect costs in Canada were mostly based on non-Canadian numbers, and were not based on a very large number of studies. So the indirect cost of caring for people with IBD was about $1.29 billion per year, or $4,700 per patient, again, very similar to the direct cost. And that's around the same as what we've seen in 2008 and 2012. Again, very different methodologies in the three reports, so you can't really compare it very much across reports. So the different types of indirect costs that we were able to estimate were short and long-term productivity losses, premature retirement, which I'm going to come back to in a second, premature death, and out-of-pocket expenses. That premature retirement number is huge, and it's really based on a single German study, which showed that Germans with IBD retired 20 years, 25 years earlier than the general population. I have a really hard time believing that's applicable to the Canadian or American. I don't know how you guys feel, but I can't imagine people are retiring at 45 because they have IBD. So I think we really need to improve our numbers. Yeah, we need to improve our numbers to try to estimate costs a little bit better in terms of the indirect costs. Gaps in knowledge in terms of the cost, really sparse data, as I mentioned. There have been no studies looking at whether treating the IBD results in better overall costs, indirect and direct, and the balance between direct and indirect costs. So we really need to do that. And actually, Laura Targonic has just submitted a CIHR grant to look at this exactly. There were unknown indirect costs, so things like professional development and how they developed through their career were not measured in the literature, as well as caregiver burden. And there was really no information about indirect costs in Canadian children or the indirect costs to their family if the child has IBD. So finally, I just want to end off with a few slides on the research landscape in Canada. And I think this we were really proud of, and we can trumpet to really to the donors who are giving money to conduct research in IBD in Canada. And what we found in terms of doing a review, and CIHR actually helped us with this review, to look at who was funding IBD research in Canada. Most of the funding did come from CIHR, the Canadian Institute of Health Research, that's your NIH equivalent. But the second largest funder was from Crohn's and Colitis Canada, with the third being the National Alliance of Provincial Health Research Organizations. That's the provinces providing research funds. You can see that group in gray has shrunk significantly. So Crohn's and Colitis Canada really is the #2 funder of IBD research in Canada. We fund about $115 million over the last 5 years in IBD research, which compares favorably to research in Canada for MS, type 1 diabetes, and Parkinson's, if you don't look at the prevalence of these diseases, and if you don't compare it in terms of the funding per patient living with diseases in Canada. And unfortunately, we're investing less per patient in Canada in IBD research than either MS and Parkinson's disease, and only slightly more than type 1 diabetes. So I think we have a ways to go in terms of investing in this disease, which is extremely high prevalence in Canada. But in terms of research, we consider ourselves punching above our weight. We're obviously not publishing as many papers as the United States with a tenth of the population, but over the last 5 years, we published 902 papers in the literature looking at Crohn's and colitis, of which we're #2. We're proud of being #2 behind the Netherlands for the proportion of the country's publications in the top 10% impact journals, as well as average relative citations. And we looked at other measures of journal publication impact, for better or worse. They're not great measurements, but we're always around #2 behind the Netherlands in terms of the impact of our research in IBD. So to conclude, Canada has amongst the highest rates of IBD anywhere in the world. Did I mention that already? I think I did. And it will affect about 1% of the Canadian population by 2030. The impact report is really considered to be a tool, a report from scientists to Crohn's and Colitis Canada in order to increase the insight of the disease burden on the patient, provide an overview of the current Canadian literature, and recommendations overall of where Crohn's and Colitis Canada should be going in terms of funding of research and providing advocacy and providing improved quality of life to patients. Many of the findings can be extrapolated to the United States, especially more of the prevalence numbers. I really do think that your prevalence is probably rising the same way that ours is. And so I think this impact on the healthcare system is important. And the fact that your cost of caring for patients with IBD is so much higher makes the rising prevalence even more important for you, and the sustainability of the healthcare system really important. So we need to develop new models of care of dealing with rising prevalence, particularly in special populations like children and seniors. And we need to look at whether these direct costs due to the use of biologics offset the improved quality of life. We're never going to be able to find cost effectiveness there, but could we find better benefit to the economic system and to the patient themselves by using these medications. In terms of future directions, the report is being used now. There's advocacy documents already on the Crohn's and Colitis website that really translate it into a digestible format. Hopefully it'll help guide Crohn's and Colitis Canada in terms of their research priorities in health services and population health research. And we consider it a living document. For example, there was one chapter that we really did want to include, and that's the chapter on women living with IBD. And there was just not enough research, especially Canadian research, to justify the full chapter. So we consider this a living document where we're not going to wait 5 years to update it. It will be updated online with new chapters added, hopefully one on women living with IBD and pregnant women living with IBD. And so with time, more will be added to the website. Thank you very much. A few minutes for questions.
So Eric, really impressive, beautiful work and such coordination of everyone in the country. You guys have best evidence. My question is, it's easy to understand how to translate descriptive epidemiology into act for the healthcare system. But I think where epidemiology is not done well in general, translating to understand why these are occurring, especially children, why does Nova Scotia have such high incidence. So could you talk a little bit more about how you'll translate the descriptive epidemiology into understanding why people get these incidents?
So
geocode, geographic analysis.
Yeah. So I focused more on that yesterday as we ran around. Obviously, you don't come to pediatric rounds, but we are. We understand that. I mean, really, this is descriptive and this is hypothesis generating information, but we really do take it back to the lab and back to the patient in order to try to find out why these things are happening. So an example that I gave yesterday was that of air pollution. So Gil Kaplan, using the thin database in the UK, found that certain air pollutants were at increased risk of developing, people living in neighborhoods with high air pollutants were at increased risk of developing early onset IBD, so under the age of 3. And then Karen Matson at the University of Alberta took that information back to the lab, fed her mouse model particulate matter, so the air pollutants, and found that there was upregulation of pro-inflammatory cytokines, decreased diversity of the microbiome, and when it was fed to mouse pups, so children, early life colonic inflammation in those patients. We're now looking at, we've sort of replicated it, looking at more specific air pollutants in Ontario. A master's student is working on that now. We haven't published it yet. But at Health Canada, we'll collaborate with a mouse researcher who is able to have the mice inhale the air pollutants. And then one of my colleagues, Alain Stinzi at University of Ottawa, we can then measure the microbiome in the mice to see why it's changing, potentially then, hopefully, changing it, intervening and changing it back to a healthy state so that we can prevent the disease going forward. So it's that sort of thing that I think epidemiologists collaborating with basic scientists and clinical researchers to try to identify why the findings we're making at the health system level or the population level is occurring will be the future of IBD, and that will lead to hopefully prevention, right? Intervening at either a population level or intervening at an individual patient level to prevent the disease going forward. So there's no doubt there's lots of work there to do, but we're not going to work in isolation anymore, right? We're really, translational research is not just bench to bedside. I think it's now epidemiology to bench and then to bedside as well.
That's great. I thought the air in Nova Scotia was very clean, though.
Yeah, the Nova Scotia finding, we have no idea why. I mean, part of it may be coding of their databases. Maybe we're not identifying patients properly and there's more false positives. Although speaking with Tony Otley and Jen Jones, they're seeing a lot of IBD for such a small province. It may be genetics, the Scottish influence, and I guess you guys all heard, or some people, Charlie Lee here, they're seeing very high incidence of IBD in Scotland as well, and there's more Scottish genes than
Scotia and Nova Scotia.
Yeah, exactly. I mean, there's a lot of shared genetics there. There's fewer immigrants in Nova Scotia than there are in Ontario, for example. So Chinese immigrants who have low rates of IBD, that may be a reason. So it's hard to say. We're working on it.
I just like the fact we have jobs.
Yeah. It's not going to be a shortage of work, that's for sure.
And it's been the burden of disease, and I there's other costs tied to being on biological or immunomodulators and other comorbidities. So
And we don't know all these children who eventually will be seniors. You know, children have more extensive disease and are much more likely to be on biologics. Does that mean when they're 70, they're also going to have extensive disease and be on biologics? We have no idea. If that's the case, we're in a lot of trouble. But, we'll have to see.
That's great. Thank you so much.
Thank you.